Assalamu alaikum. This is Dr. Shafiq Cheema. Today we will be talking about a nephrotic syndrome. This is a very important topic for medical students because it's not only commonly asked in their exams, but also sometimes you could have a long case in which patient have edema or generalized edema and underlying diabetes and diabetic nephropathy is the diagnosis, but patient has presented with nephrotic syndrome secondary to diabetes. So this is a significant topic, and this is also very relevant for the people who are in practice, the medical officers, the house officers, the general practitioners, and also I would say the postgraduate residents who have just started the fellowship. This is not intended for them because this is kind of basic, but still this could be the starting point. Currently, I'm working as a professor and head of nephrology department at Allama Iqbal Medical College, Jinnah Hospital, and I'm diploma at American Board of Nephrology as well as internal medicine and fellow of American College of Physicians and American Society of Nephrology. This is my WhatsApp number where I could be reached at. If any student or any GP has any question, don't forget to give a reference of Good Doctors by Dr. Shafiq Cheema. That way I would know what is this in reference to. So this is almost most of you would know the definition, what exactly is nephrotic syndrome. And we started learning about it, I would say from FSC and A level. It's characterized by if someone has proteinuria more than 3.5 gram per day. Normally, we all leak protein, but that is less than 200 milligram per day. So if it's more than 3,500 milligram per day, that is considered nephrotic range proteinuria. And if that is accompanied by hypoalbuminemia, in which albumin is less than 3.5, normally albumin is more than 4 gram per deciliter in the serum. And as a result of that, patient also develop edema, hyperlipidemia, and lipiduria. This whole set of symptoms is called nephrotic syndrome. We had seen it not uncommonly, people just presenting with the nephrotic range proteinuria, and there could be certain reasons for that, and not full-fledged nephrotic syndrome. If you have proteinuria less than 3.5 gram, that would be subnephrotic range proteinuria. And less than 200, and some books say 300 milligram per day is normal. So normally, the protein and the albumin stays within the capillary lumen in the kidney. If there is any injury to the capillary wall, the protein could leak and come in the urine. This is the underlying concept. And there could be different mechanism of this injury to the podocytes or the endothelial wall. Normally, the negative charge and size of the protein keeps the protein within the blood. But whenever there is a disruption of this barrier, the protein could leak and could cause glomerular proteinuria. Remember, proteinuria could be a tubular proteinuria, in which most of the protein comes from the tubule, not from the glomeruli. And proteinuria could also be overflow proteinuria, like in multiple myeloma, in which overproduction of light chain is excreted into the urine, but that would not be albumin. Sorry. So normally the endothelium or endothelial surface, basement membrane, and food process of the podocytes or the epithelial cells keep the protein inside. Many studies have shown it's basically injury to the podocytes or epithelial cell which causes the actual damage. That's what happened in podocytopathies like minimal chain disease or FSGS. And even in membranous, the anti-PLAR antibodies are also against the epithelial cell proteins. This is just to show you there are certain signs which you could appreciate. These little white lines called Merker's lines. These are present in people with hyperlipidemia. These are different from half and half nail, in which half nail is white, half nail is brown, which is hallmark of CKD. People could have lipid deposition here, xanthomas. That could be a manifestation of hyperlipidemia, which was a result of nephrotic syndrome. You could have periorbital edema. This is waking up early in the morning. This is maybe end of the day. So the edema is dependent. In the morning, you could see more on the face. In the evening, you could see more edema in the dependent area like legs because of the effect of gravity. Lipiduria. It could look like a symbol of Maltese cross. It's a famous symbol. So the lipid or the fat leakage in the urine is manifested like this under polarized light. How to quantify urine protein? Normally, when we do the dipstick, we have 1+, 2+, 3+, 4+ protein. That does not mean anything. It only means there is an increasing degree of proteinuria, but then we have to quantify. The gold standard is 24-hour urinary protein and creatinine calculation, which will tell you how much someone is excreting in a day. But a semi-quantitative way, spot urinary protein and creatinine ratio will give you almost a very close estimate of 24-hour urinary protein excretion. You could check for protein or you could check for albumin. Just remember 70 to 80% of total protein is albumin. And if you are defining nephrotic syndrome based on the albumin, 24-hour, that's like around 2.2 gram or 2200 milligram rather than 3.5 gram in case of proteinuria. So as I said before, proteinuria could be subnephrotic or nephrotic range, or some people could have 20-30 gram of proteinuria. We could loosely call them heavy proteinuria. It's not really a term. The best way to describe someone's proteinuria is to give exact quantity, like 1350 milligram. I would know it's a subnephrotic range, and I would know it's way above the normal range. Albuminuria is also further classified based on the urinary albumin creatinine ratio, A1, A2, and A3 category. A1 is less than 30, which is normal, 30 to 300 milligram. It used to be called as microalbuminuria. Now it's called moderately increased albuminuria. And A3 is more than 300. It used to be called as macroalbuminuria. Now it's called severely increased albuminuria. And this I already told you, albumin creatinine ratio of more than 20 to 20 milligram per gram is also considered nephrotic range, similar to 35 milligram. What is the mechanism or pathophysiology of nephrotic syndrome? You lose albumin in the urine, so that causes hypoalbuminemia, and that leads to edema by two mechanisms: sodium and water retention by the kidney, overfill theory, and then there is underfill, most popular theory, that decreased plasma oncotic pressure and activation of renin-angiotensin system leads to edema as a result of hypoalbuminemia. And also a non-specific stimulus would cause synthesis of VLDL, LDL from the liver, and that increases the lipid level, causing hyperlipidemia. And you lose many anti-clotting factors in the urine, increasing hypercoagulability. For example, antithrombin 3, protein C, protein S. So in many cases in which there is a heavy proteinuria, like in membranous, causing significant hypoalbuminemia, we do need to give them anticoagulation, sometime in the form of just aspirin, but if it's very severe, heparin as well, to prevent the clotting, to prevent DVT, pulmonary embolisms. So nephrotic syndrome is not a benign condition. It could increase the risk of infection. It could increase the risk of thromboembolism. It could predispose you to hypovolemic shock. It could increase the risk of coronary artery disease. And it could also cause loss of some other hormone binding protein, which could affect the hormone level and their effectiveness. Generally, any patient with nephrotic syndrome, irrespective of the cause, will be managed non-specifically by salt restriction, by giving them ACE and ARB, which will decrease the proteinuria unless there is a contraindication. Use of diuretics as needed, especially furosemide and lipid-lowering agent. This does not depend on the underlying cause. You could do it on anyone, like you as a medical student or medical officer could do it. These are the most common causes of primary or idiopathic nephrotic syndrome: minimal change disease, mostly in children; FSGS, most common cause in adults as well as in African Americans; membranous nephropathy, overall the most common cause; and MPGN, which has a overlap. It could cause nephrotic syndrome or nephritic syndrome. This is in more detail. Diabetes is overall the #1 cause of nephrotic syndrome. And then there are dysproteinemias like amyloidosis and light chain deposition disease. Membranous nephropathy in most cases is idiopathic, but could be secondary to lupus, hepatitis B, certain drugs, occult carcinomas. Similarly, MPGN could be idiopathic without any underlying cause, but could be secondary to infections and hepatitis C and non-Hodgkin lymphoma. Collapsing glomerulopathy is a type of FSGS, happens in HIV. Minimal change disease, most cases idiopathic, but could be secondary to NSAIDs and Hodgkin lymphoma. FSGS, many cases are secondary, some are primary. It could be end result of any kidney disease like long-standing nephron loss, sickle cell disease, reflux nephropathy, analgesic nephropathy, heroin abuse, heel proliferative GN, and immune-mediated GNs like diffuse proliferative lupus nephritis and Hanoch-Shanlin purpura. And preeclampsia, toxemia could also cause nephrotic. So these are overall causes. We will go over few of them which are important for the medical students, starting from minimal change disease. It's a disorder of podocytes. It may be linked to T cell mediated immunity. Recently, there was an article in the New England Journal in which they found anti-nephrin antibodies. So this was idiopathic all along. Recently, it seems like it has autoimmune pathogenicity. Secondarily, it could be caused by drugs and lymphomas. Clinical and laboratory features. It causes steroid-sensitive nephrotic syndrome, main cause of nephrotic syndrome in the children. Renal function and blood pressure usually are normal, and there are no known serological abnormalities except recently found anti-nephrin antibodies, but it's commercially not available yet. On light microscopy, glomeruli are normal. That's why it's called nil disease or minimal change disease. Immunofluorescence is negative too. On EM, you will find diffuse effacement of the podocytes. Normally, podocytes are like this. Food process, you will see them effaced. And you could appreciate it here. This is the food process, and here you see one straight line. So this is called effacement of the food process, or flattening of the food process. It responds very well to steroids. Relapse is common. It's called disease of remission and relapses. In some of those cases, cyclophosphamide and cyclosporin is given. They are very effective, and it does not progress to chronic kidney disease. That's the good thing about it. I usually tell my patients that it will come and go, but you will not develop end-stage renal disease secondary to that. The second type is focal segmental glomerulosclerosis, FSGS. Focal because only some of the glomeruli are involved. Normally, each kidney has 1 million. So some of that 1 million are involved. And the glomeruli which are involved, only segment of it, not globally. So it's not global glomerulosclerosis, it's focal segmental. Some glomeruli and parts of those glomeruli are involved. This is very common in African Americans. It is one of the commonest entity, also in HIV, heroin abusers. Let's see the pathogenesis of it. So primary FSGS is idiopathic. It's common cause of adult nephrotic syndrome, especially among blacks. Secondarily, as I said, there are many causes. It usually present as asymptomatic subnephrotic range proteinuria. So the difference between primary and secondary glomerular disease, primary will present suddenly, rapidly, while the onset of the secondary disease will be slow, insidious, and primary will cause more proteinuria, more edema. In secondary, you could have less proteinuria and less edema. There are many causes. Whatever could lead to decreased nephron mass could cause FSGS, VUR, sickle cell disease, renal ablation, heel proliferative GN, morbid obesity. In obese people, if they leak proteinuria, this could be one of the reasons. Primary idiopathic, like minimal change disease, 40% would respond to steroid, minimal change, 80%. Less responsive, you would use cyclosporin or MMF as a second agent. You add to the steroid. Sometimes we give tacrolimus also. And the response is poor as compared to minimal change. These people will develop end-stage renal disease. Secondary FSGS, you treat the underlying cause, like if someone is obese, say 200 kilogram, if they undergo a sleep procedure or surgery and they lose weight, their secondary FSGS could get better. If it's secondary to HIV nephropathy, you treat the underlying disease with highly active antiretroviral agents. But the non-specific treatment like ACE, ARB, diuretics, that you could give it to them like any patient with nephrotic syndrome. Histopathology, in early disease, glomeruli might be normal. Late, as I said before, there would be areas of segmental fibrosis and sclerosis and hyalinosis and mesangial expansion and matrix fibrosis and tubular atrophy. Immunofluorescence could be positive for IgM and C3, especially in the sclerotic lesions. Electron microscopy, for primary, you will see diffuse effacement of the food process. And secondary, you will see patchy or focal. Minimal change disease has the same characteristic too. Primary diffuse effacement and secondary patchy effacement or focal. That's why maybe it's more abrupt and severe in primary and there is more proteinuria. Area of sclerosis, it has different types. Perihilar, deeply and collapsing cellular, depending upon where the area of sclerosis is. It's again primary and so I would end FSGS here and we will talk about membranous nephropathy. Again, all the glomerular disease, in most cases, their underlying etiology is primary or idiopathic, and all the immunosuppressant treatment we give is for primary and idiopathic, not for secondary. For secondary, the treatment would be underlying secondary disease. For example, if hepatitis B causes membranous nephropathy, you treat hepatitis B. You don't give them immunosuppressants that will replicate the virus more and it will be even dangerous. So primary, it's now considered autoimmune disease because we recently found some antibodies against podocyte protein, phospholipase A2 receptor. It's called anti-PLAR antibody or anti-PLA2 receptor antibody. So to me, this is also an autoimmune disease. It's also a podocytopathy like minimal change and FSGS. Secondary to SLE, FB, C, cancers, NSAIDs, there are many other causes of secondary membranous. So basically these antibodies against a protein on the podocyte making antigen antibody complex, immune complex, which are deposited in the form of humps here. And if you see, this is under epithelium. So these would be subepithelial humps or deposits of immune complexes, which would initiate the response and activation of complement and all that. So we could diagnose based on this. If someone has this anti-PLAR antibody, that means they have primary or idiopathic or autoimmune, not secondary. Kidney biopsy will confirm the diagnosis. Early disease might not have anything on the kidney. It could be just like minimal change disease, but then you could have thickening of the basement membrane. In advanced disease, you could have that spike and dome pattern, especially on the silver staining, subepithelial deposits. These one, you could see them. And then obviously there will be worsening IFTA, interstitial fibrosis and tubular atrophy. Non-specific treatment is the same for all nephrotic syndrome. Specifically, you must have heard about Ponticelli regimen, in which you give cyclophosphamide and steroid in a specific way. And there is a modification of that protocol too. It's given for 6 months, have very good response. Excuse me. Lately, there is a significant role of rituximab, which has been evolving. Calcineurin inhibitors have role. For secondary, you treat the underlying cause. MPGN, also known as mesangiocapillary GN, it could cause nephrotic or nephritic pattern. Whenever there is a nephritic pattern, you will see some RBC and RBC casts in the urine also. But it could also present just like with proteinuria and nephrotic syndrome. So as the name indicates, it's membranoproliferative. So there is a membrane capillary wall thickening as well as proliferation. You will see more cells in certain areas, some mesangial expansion, some thickening of the basement membrane. Pathophysiologically thickened GM due to deposition of immune complexes, similar to membranous. New basement membrane formation, increased mesangial and endocapillary cellularity, which gives glomeruli its lobular appearance. And the deposition here is subendothelial immune complex deposition. In fact, in the older classification, it's classified into type 1 and 2, type 1, 2, and 3, subendothelial, and then the basement membrane, a dense deposit disease, and subepithelial deposits. But membranoproliferative is not just considered as a pattern of injury. And the new terminology for this is C3 glomerulopathy or C3 glomerulonephritis. That's beyond the scope of medical students, so I'm not going to go into the detail. So again, there will be thickening of the capillary wall and there will be increased cells, and immunofluorescence will show staining. This is dense deposit disease, DDD, in which the whole basement membrane is replaced by the dense deposit. In the older classification, this was type 2 MPGN. There are different mechanisms: immune complex deposition like membranous nephropathy, dysregulation of alternative complement pathway. That's what happens in C3GN or C3 glomerulopathy or complement mediated MPGN. Secondarily, it could be caused by infections like Hep B and C, chronic bacterial infections, fungal infections, autoimmune disorders like SLE, Sjögren syndrome, rheumatoid arthritis, monoclonal gammopathies. There are so many secondary causes for MPGN, like membranous and FSGS also. So complement-mediated MPGN is secondary to dysregulation and persistent activation of alternative complement pathway. It could be secondary to certain mutations in the complement regulatory protein, certain autoantibodies against complementary regulatory proteins, So there are different mechanisms which predispose someone genetically for C3 glomerulopathy or MPGN. We check their serologies and cultures. We look for monoclonal gammopathies by doing serum protein electrophoresis, free kappa lambda light chain, urine electrophoresis, and immunofixations. For autoimmune diseases, we do autoimmune workup like ANA and ENA profile and NDTS DNA. We check complement level to see if there is a deficiency of C3. But obviously, biopsy is the gold standard. On biopsy, you could have intense C3 staining as well. How do you treat MPGN? You treat the underlying cause if it's a secondary. For example, if someone has hepatitis C infection, you give them directly acting antiviral agents, and that will help MPGN secondary to that. For idiopathic, when there is no secondary cause, you give them immunosuppressants, and there is a role of steroids, cyclophosphamide, MMF, rituximab, CNI, eculizumab. And it depends on the situation and scenario, and we can't go into the details for that because that would be beyond the scope of medical students and general practitioners. That's where you probably refer them to nephrology. So I hope I covered all of it. I did not cover some of the secondary causes like diabetic nephropathy causing nephrotic syndrome because that's a separate topic and there is another lecture on it. Please subscribe to our channel, Good Doctors by Dr. Shafiq Cheema. Currently, we are uploading lecture in nephrology and gastroenterology, but soon we will be adding more topics and lectures to it. I hope you liked it. Thank you very much.